Good morning, everyone. Good morning, and welcome to the Harvard Osher Center monthly Grand Round series. So my name is Gloria Ye, and I serve as the Director of Clinical Research of the Osher Center. I'm very happy to welcome you this morning and introduce this morning's presentation. We have a very special presentation for you this morning. Um, So perhaps you've all been enthralled and inspired by the Summer Olympics in Paris the last couple of weeks. So I know I sure have. So we thought that it might be really fun to follow the Olympic theme this summer and have a grand rounds today that's centered around integrative medicine research that intersects with gait and movement and physical activity and psychology. Um, okay, so um, let me just share my screen here. Everybody see that okay? All right. So, so each of our three presenters this morning are recent graduates of our postdoctoral research fellowship program. So this is a program that the Osher Center is particularly proud of, the program and its fellows. This is the Harvard Medical School Research Fellowship in Integrative Medicine that's been continuously funded through a NIH T32 for the past 25 plus years. The fellowship is administratively based within the Division of General Medicine at the BIDMC, but it's a Harvard-wide program with the core fellowship leadership within the Osher Center. So the postdoc fellows across multiple disciplines spend 3 years with us training for academic careers in integrative medicine. And we recently also have a sister affiliate fellowship that runs alongside the T32 for a chiropractor fellow, and this is funded through the NCMIC Foundation. So again, we're extremely proud of our fellows, the work that they do, and their accomplishments. So we're going to have three distinct, let me see here. Here we go. Three distinct yet complementary presentations by our fellow graduates. Dr. Burton will speak on her work examining gait and mobility and chronic neck pain. Dr. Doorley is going to speak on his work as a sports psychologist, including work with Team USA at the recent Olympics. And Dr. Muñoz-Vergara will speak on a very timely study on physical activity and risk of COVID infection and hospitalization. So all of these three presentations, I think, really illustrate interesting aspects of the mind-body connection. So hope that you'll enjoy. All right. So a couple, I guess, housekeeping things in terms of our meeting format. So we've recently gone to a more open Zoom meeting. So hopefully there'll be a little bit more interaction. We'll ask that you just remain on mute until you're prompted for the question and answers towards the end. At any time, you can type any comments into the chat box, but for the questions to the speakers, we ask that you put that into the Q&A function. And you can put in questions at any time, or you can hold your questions until the very end during the Q&A section where we'll open it up and you can ask your question directly. Yes, and you can use the reaction buttons, and the meeting is being recorded. And for CME credit, if you want to request CME credit, here's the email and the information you need to send. All right. So let me go ahead and stop share, and I'll let Wren bring up your slides, and I'll give you a little introduction. And what I'm hoping to do is I'll introduce each of the speakers right before their presentations. And I think we'll go ahead and each speaker will have about 15 minutes. We'll go through each of the three talks and save the Q&A for the very end. And hopefully we'll have some nice discussion. Okay. Oops. So our first speaker is Dr. Wren Burton. Burton is a clinician researcher at the Osher Center. She's a recent graduate of our fellowship this past June. She has a bachelor's of science in exercise science from the University of New England. She has a doctorate of chiropractic from the Palmer College of Chiropractic and a master's in public health from the Harvard T.H. Chan School of Public Health. She specializes in gait health and fall prevention and non-pharmacological approaches to chronic pain. Wren, go ahead and take it away.
Awesome. Thank you so much, Gloria, and good morning, everybody. Today, I'm very excited to talk to you about an often somewhat overlooked aspect of health, which is our gait. And specifically, we will be exploring how gait can serve as a measure of whole person health in individuals with chronic pain. So before we dive in, I would like to mention that I received funding from an NCCIH Complementary and Integrative Health Practitioner Supplement. And I'd also like to acknowledge all of these stellar individuals who I've had the joy of working with, both throughout my fellowship and in the present. Without them, absolutely none of this would be possible, so I cannot thank them enough. I want to start in on some background as to why this is important. We know that gait is something that we use every single day to get from point A to point B. And we can see that pain and mobility are very closely intertwined. And there's growing evidence that supports a theoretical model where the relationship between pain and gait is multifactorial. And diving deeper into this model, we know that chronic pain may lead to changes in cognition and thus lead to reductions in the quality of one's gait. It's also shown to potentially compete for attentional resources and act as a subconscious distraction for disrupting mobility. And not only is pain distracting, but it has adverse emotional impacts. So the fear of increasing one's pain, the fear of movement, feelings of depression and catastrophization, causing those with pain to ruminate and magnify their pain experience. And these emotional factors have been linked to decreases in physical function and identifiable changes in one's gait as well. And then, of course, we have our physical causes, including things like reductions in the function of the specialized receptors in the sensory motor system that live within our cervical spine and all across our spine, comprising our balance and ambulatory posture. In our research, we've chosen to focus on neck pain specifically because it is relatively understudied compared to other spine pain conditions, and it may have a unique impact on how people move compared to other pain conditions as well. And so this leads us to two key questions. First, how can we understand the relationship between these two potentially fall risk factors, if we want to call them that, of mobility quality and chronic pain? And then second, what interventions can we develop for individuals with these risk factors to prevent reductions in mobility or worsening of one's chronic pain? And to answer these questions, again, we want to visualize the relationship between neck pain and movement. And so in order to do this, we've mapped outcome measures onto this theoretical model and conducted a cross-sectional study as a first step. And so in this study, we aim to assess how the presence or the absence of neck pain impacts gait health, specifically looking at gait speed and stride time variability as those measures of gait health. When we look at those measures of gait, it's important to note that typically a higher gait speed and a lower stride time variability indicate better gait health. So we want to walk fast and we want to walk reliably. And so for this study, we recruited about 100 participants in a 60-40 ratio of those with neck pain to those without. And we asked participants to walk across a gait mat that collected these outcomes while completing 4 different tasks, including walking at a preferred speed, performing physical tasks like turning their head side to side, turning their heads up and down, and cognitive tasks like counting out loud backwards. And our preliminary results were quite interesting. We have them demonstrated here visually. We can see individuals with neck pain, individuals without neck pain, and then we have all of our different tasks listed out here as well. And we have shorter arrows demonstrating shorter or slower gait speeds, and these higher amplitude arrows indicating those with higher levels of variability. And we can see that those with neck pain consistently had slower gait speeds and higher levels of variability compared to those without neck pain, even under the dual task conditions. And this is further supported by a meta-analysis that our team completed on over 500 participants across different studies. And this showed large effect sizes of chronic neck pain on gait speed and varied effect sizes of chronic neck pain on cadence, with the most notable impacts occurring under these dual task conditions. And so we know that gait is just one piece of this puzzle. So we've also looked at these cognitive and emotional health components. For the cognitive components, we measured executive function and verbal working memory. And interestingly, individuals with neck pain showed worse measures in both areas. And on the emotional side, we looked at kinesiophobia, so that fear of movement, and pain catastrophizing. And those with neck pain, again, had higher levels of both of these measures compared to those without. We also examined physical components using several subscales from the PROMIS 29. And in this, we found individuals with chronic neck pain reporting significantly worse sleep, lower physical function, and higher levels of pain interference. If we circle back to our second research question, we want to know what interventions are there for individuals with these risk factors to really prevent those reductions in mobility quality and the worsening of chronic pain. And so when we think about gait going forward, we really consider it in the context of public health overall, specifically as something like a proxy for falls. And this leads us to consider particular populations for who this research is especially relevant and what it can represent as a target for future interventions. So even further, when we look at that previous research and our current evidence, we start to wonder, who is this most relevant to and what interventions might be the most important to explore in this realm? And there's a myriad of interventions that could be explored to prevent the worsening of these issues individually. However, we are particularly interested in interventions that could address both mobility and pain simultaneously. And so one intervention that really shows promise is chiropractic care. And chiropractic care is interesting because it has the potential to impact multiple modifiable fall risk factors. It could potentially improve balance and coordination, reduce pain, improve flexibility, and even enhance proprioception. And so our team conducted this systematic review of 21 studies in chiropractic care for fall prevention. And the key findings were really that despite the potential positive impact of chiropractic care on these fall risk factors, we found virtually no evidence evaluating the long-term impact of chiropractic care on fall prevalence in older adults. And so it's important to note that while chiropractic care shows promise, we really need more robust evidence to fully understand its impact on fall prevention and mobility in individuals with chronic pain. And so this is why we're moving forward with more comprehensive studies, which I will discuss in a moment. As our next step after this review, we partnered with an incredible team at university hospitals to assess retrospective data from a large database. And our results showed a lower incidence of falls over 13 months in a spinal manipulation cohort compared to a non-spinal manipulation cohort. And this is a relatively very exciting finding that should still be interpreted very cautiously, as we're really only able to assess this single component of chiropractic care using these large databases like this. And again, the key to really pushing this research and evidence forward is to approach this from this whole person health perspective. So we're not just looking at spinal manipulation or pain or mobility as single components, but how those factors interact with other components of health to impact individuals' overall well-being and quality of life. And so as we move forward in our research, we are progressing from reviews and observational studies to clinical trials. And we're particularly excited about exploring multimodal approaches that combine different interventions to really address the complex interplay between pain, mobility, and fall risk. And that kind of holistic approach holds a great deal of promise for meaningful improvements in the lives of individuals with chronic pain. And so we've recently finished up and just published this single arm mixed method study on 15 nurses with neck pain within the Mass General Brigham system right here in Boston. And this helped us not only operationalize the multimodal components of chiropractic care and Tai Chi for research, but also determine the feasibility of combining these interventions and collecting these gait outcomes. Interestingly, also observed some very promising preliminary results related to reductions in pain and pain-related disability. And currently, we are actively recruiting and running a 3-arm NCCIH NIH funded study that includes chiropractic care plus Tai Chi plus usual care in one arm, chiropractic care plus usual care in another, and then usual care alone in a third arm. And as I wrap up this whole discussion today, I really want to focus how we're bringing all of those elements together in this current research study. In this study, gait assessment is playing an important role, not just for me, but for our entire study team. So we're collecting these measures at 3 key points, along with the other outcome measures at the baseline visit, at the 16-week mark after participants complete their intervention, and then again at 24 weeks after 8 weeks with no intervention. And that longitudinal approach is going to allow us to not only see any immediate effects of these interventions on these gait outcomes, but also to assess if there are any of those sustained benefits over time. And so we've seen the importance of this throughout this presentation, discussing how gait serves as a window into whole person health. And we've seen how chronic neck pain affects not just movement, but also cognitive function, emotional well-being, and overall quality of life. And so by carefully measuring these gait parameters at each of these time points, we are essentially taking the pulse of an overall health status of these individuals. And so our assessment is going to include the measures we discussed earlier of gait speed and stride time variability, how those measures change under different conditions. So again, including dual task scenarios that challenge physical and cognitive capabilities. Again, the goal here, not just to reduce pain or improve gait in isolation, but to improve and promote whole person health. And so as we move forward, we're very excited about the potential of this to make a real difference in the lives of individuals living with chronic pain. And I'd like to thank you all for your attention today. I hope this has given you some background information and new perspective on the importance of gait in health assessment and the promising directions that we're taking in exploring pain management. Happy to take any questions at the end, and we've got great speakers lined up for you all. So thank you all again for your attention.
Awesome. Thank you so much, Wren. It's just really fascinating to think about, human gait as this function of so many of the interacting systems. It really does illustrate whole person health, and that body connection. Okay, so for those of you who just missed a little bit of the intro, we will take all the questions at the very end, at the end of all 3 presentations. You can put some of your questions, if you have them now, for Dr. Burton into the Q&A function, or you can hold them and raise your hand at the end when we do our discussion. So go ahead, Jim, and you can share your screen while I give a little introduction here. So our next speaker is Dr. James Doorley. Dr. Doorley is a licensed clinical psychologist and a certified mental performance consultant through the Association of Applied Sports Psychology. He also just graduated from our fellowship in June, where he explored the mind-body connection in the context of orthopedic injuries and psychological and behavioral interventions for chronic musculoskeletal pain, such as psychologically informed physical therapy. He's now a full-time psychological services provider for the U.S. Olympic and Paralympic Committee, just returning from the Paris Olympics. He has also worked as a clinical and sports psychologist for the MGH, Massachusetts General Hospital Sports Psychology Program, for Northeastern University, for the Boston Ballet, for the U.S. Naval Academy, and the New England Revolution, among others, to round out this sort of all-star portfolio. All right, so I hand it over to you, Jim.
That is very kind. Thanks, Gloria. Yeah, mostly recovered from the travels and really honored to be here to speak with you all today and be among these great speakers and other fellows. So my talk will be taking a little bit of a different angle. I won't be so much going through the results of a study or multiple studies. I'll be kind of talking about how my work and research throughout the fellowship has informed the more applied work that I'm doing now in sports psychology. A lot of the work, as Gloria said, that I did was focused on mind-body interventions for pain and for orthopedic injury. And it just so happens that that dovetails quite nicely with a lot of the work I do in sports medicine now, working with athlete populations struggling with injury and trying to return to sport effectively. So coming back from the Olympics and trying to consolidate and reflect on all of these crazy experiences, I reflect on the significance of the mind-body connection. Through our fellowship, this is really at the core of the work that we do, is the intersection and the integration of mind and body. And I think there are few better examples of this integration than watching some of these elite athletes do what they do. Obviously, the physical preparation and the physical performance is incredibly impressive, but also mentally being able to perform at the highest level at the biggest stage with so much pressure. A lot of these athletes are just competing in one Olympics. It's kind of like they've been training their whole lives for this one moment. So I think this is a great testament to how mind and body can work together in ultimate harmony. And again, a lot of the work that I do with athletes as part of the sports medicine division of the U.S. Olympic and Paralympic Committee is getting asked to work with athletes struggling with injury, trying to return back to sport. Maybe they're physically healed. They've hit a lot of their rehab benchmarks, but something isn't quite clicking and they're not able to return to their former selves back on the field of play. And this has me thinking about some of the factors that are failing athletes, or how can we do better to really integrate mind and body approaches to help athletes return to sport more successfully and better cope with pain and the stress of rehab. And looking at the sports medicine literature, there are a whole lot of innovations happening. There are a lot of technological innovations in particular. So I'm kind of curious, how well are these innovations helping athletes return to play? Some of these innovations are not particularly new, but are being uptaken in clinical practice more and more. Things like PRP injections, stem cell therapies, diagnostic ultrasounds, and of course, in the last couple of years, a quantum leap in kind of research and the capabilities of machine learning and AI, and of course, advances in equipment. That's something that sports teams and organizations are always interested in. So a lot happening in the field. But I'd like you to imagine for a moment that, let's say you're a sports medicine practitioner of some sort of team physician, physical therapist, and all these technologies and innovations are at your immediate disposal. You can use any and all of them as you see fit. Will you have everything you need to help your patients cope with pain, reduce fear of re-injury, be optimally motivated during rehab, which is incredibly important, and return to sport with more confidence in their body and in their skills than they had before? I would say not necessarily. I'm curious what you think about this. So why, with all of these innovations, all these biomedical innovations in particular, do we maybe still not have what we need to help athletes with these crucial elements of rehab? Well, it's likely because athletes are human beings. They're not high performance machines. More technology in doesn't necessarily lead to higher performance out, right? They're not like Formula One race car, for example. It's a bit more complicated than that. But we could consider their bodies kind of like this high performance machine, right? It's really, to use the Formula One example, it's what's inside the machine that really matters. You can have the best car on the wealthiest team with the best technology, but that car can crash in the first lap, right? It's the driver that really dictates the success. And when it comes to sport and in sports medicine, the mind is really the driver of what the body does and how well the body recovers and rehabilitates after injury. So we can think about what drives injury and recovery outcomes. There's these traditional kind of biomedical aspects the equipment that's used, diagnostic tools, the things I showed on that first slide, everything that providers learn in their kind of biomedical training. And then there's this whole other dimension of variables that really are what make the difference in athletes' recovery. If you think about all these things together, we can consider this kind of psychological readiness to return to sport. And there's a large and growing literature on psychological readiness to return to sport, which essentially shows that athletes can physically heal. All the healing that's necessary can take place. Athletes can regain strength. They can reduce strength asymmetries between an injured and a non-injured limb. They can perform well on all the clinical and laboratory tests and metrics that show that they should be ready to return to sport. And yet many, particularly following ACL injury and surgery, do not return to sport. And if they do return, they don't return to their pre-injury levels of performance. So really, psychological readiness is the linchpin in successful return to sport for athletes. All of these factors here. And an important question then is, do sports medicine providers understand this? How aware are they? And how comfortable are providers in assessing and to some extent addressing psychosocial and mind-body factors related to injury? And there's really not a whole lot of this research being done in sports medicine, but I at least can pull from some research that I and my colleagues have done at Mass General Hospital and during my fellowship. We did a series of qualitative studies interviewing orthopedic healthcare professionals at level 1 trauma centers across geographically diverse centers in the US. And it turns out that a lot of these providers, which included surgeons, medical assistants, and everyone in between, they did conceptualize good outcomes after injury as involving biological, psychological, and social factors. They seem to view a number of variables, mind and body, as important for recovery. But when you ask them, do they ask their patients any questions about their emotional state, on how social factors might be impacting recovery? A lot of them don't ask. A lot of them fear that they will somehow open Pandora's box. They worry about what could come up. They worry that they don't quite have the skills to ask these questions. And for sure, they're not psychologists, right? But my philosophy and the philosophy of many of my colleagues is that this work doesn't need to be localized to just psychologists or psychiatrists. Everyone can play a role in adopting a more psychologically informed lens to treatment. So that's what I hope to accomplish in part in my work with the US Olympic and Paralympic Committee. I'm leading this working group that's focused on psychosocial aspects of injury and recovery. And the goals here are to first increase psychological literacy among our sports medicine staff. And I'll say that I am impressed with a number of many of our providers and what they know already, but arming everyone, sports massage therapists, athletic trainers, physical therapists, with the essential knowledge that they need to understand psychological aspects of injury. And that's the first and most important step. And then seeing where we can integrate psychological assessments and interventions throughout the whole spectrum on the whole trajectory of rehab. Athletes likely need different things at different points in this trajectory. And then making this a team effort. As I said, this isn't just for mental health providers or psychologists. This is something that everyone can participate in. So I've been thinking about this process as sort of a life cycle process. Athletes are always occupying some point in this cycle. If they're not injured, then the focus is on keeping them healthy and preventing injury, right? If they are injured, then a whole series of other processes ensue from, they are experiencing acute injury. There may be a surgery. If there is a surgery, there may be a prehabilitation process if there's time, and then they proceed with their rehab and functional recovery. They eventually return to sport. And again, they're focused on health and prevention. And looking at injury in this kind of life cycle model helps us imagine and look through the research to find psychological interventions that may be particularly helpful. And so I won't go through all of these in detail, but I'll give some examples in the subsequent slides of psychological processes that may be particularly important to assess and address at various stages of this cycle. So starting with the acute injury phase, one thing that's really important here for team physicians, athletic trainers, the people who are the boots on the ground, who are kind of the first responders to an injured athlete, is simply the helping relationship. At that point, an athlete's injured. There's nothing that can be done to prevent that or reverse that. These providers are providing, physical first aid, but there's the psychological first aid aspect of things. Helping athletes process all of the complex emotions that are swirling around at this time. Feelings of anxiety and fear about what just happened to me, what's going to happen, processing the loss of what could have been had they not gotten injured, the anger of I can't believe this happened, and the regret. There's just so many injuries that happen. I've been in the ambulance with athletes following acute injuries and fractures during training and during competition with hundreds and thousands of people watching, and it's really an emotionally intense experience, as anyone here knows who has gotten injured or who's had a family member get injured. And so it really comes down to the basic helping skills, things that a lot of you are trained in, and things that as psychologists and therapists we're trained in. How are we listening? How are we validating? Can we help that athlete or patient sort of avoid common mental pitfalls and cognitive biases that can increase anxiety and distress shortly after injury? And we know from the psychotherapy literature and from the placebo literature that this patient provider relationship accounts for a really large proportion of variance in outcomes. That goes for many treatments for physical illnesses, and it goes for how athletes process an injury. And during the diagnosis, prognosis, kind of treatment planning phase, right? Communication is one of the things that we emphasize, my colleagues and I. It's so incredibly important. We can think of the times that we've been in the doctor's office and we've had a diagnosis communicated to us, and man, it's such a high stress time, and our stress and anxiety can really skew our perception of the words coming from that provider's mouth. Our words obviously have an incredible impact, as these quotes say here. And there's a Viewpoint article that I found particularly useful on this topic, which is shown here. I'd encourage you to check it out if you're curious about this. They have some interesting tips for communication, a lot of which I agree with, some of which I've kind of reshaped here. But as providers, physicians, it's important to recognize that a lot of the terms that you might be really accustomed to using can be misunderstood, especially by someone who's acutely distressed, like an athlete shortly after an injury. Terms like degenerative, chronic, damage, they're terms that are hard to get around, but they can trigger a whole web of associations that can be catastrophic for athletes. So it's important to unpack these terms, not saying avoid them, but make sure that you're clear on what you mean by those terms that you use. You want to be realistic, right, but not fatalistic. I think that's a good way of thinking about it. We don't want to underestimate that person's intelligence, because sometimes when we do, we end up using language that's overly vague and sometimes a bit inaccurate. And when our communication is vague, that's when our anxiety just likes to fill in the blanks and make things even more scary. During the functional recovery phase, as an athlete is progressing through their rehab, there's a number of psychological approaches that can be helpful here. It's really a great time for an athlete to use and start to train mental skills that can help their performance. Any kind of goal-oriented activity during rehab is helpful. Athletes may have kind of more time on their schedule that they can take advantage of. The one thing I think about here is that healing, is primarily a physiological process. I think we can say healing is something that just simply takes time. There are psychological factors that can influence. There's a literature on the impact of stress on wound healing, for example. So emotions play a role, but really, I think emotions and psychology and behavior play a central role in rehab. Once that injury is healed, it really comes down to our behavior, right? And our thoughts and our emotions influence our behavior, and our behavior dictates how fast and far athletes and we will progress after an injury heals. And this is the premise of one of the studies I worked on a lot during my fellowship with my research mentor at MGH, Toolkit for Optimal Recovery for Orthopedic Injury. We worked with patients who had sustained orthopedic trauma, and in various parts of the country, level 1 trauma centers, who had high levels of pain anxiety and pain catastrophizing, and therefore were at risk for potentially experiencing chronic pain after injury. And we gave them this whole toolkit for how to cope and how to get back to their normal activities. And it's funny how many ways there are in which I use some of these techniques for athletes. It really translates, whether it's someone in Tennessee who got in a really bad car accident who wants to get back to their office job, to an Olympic athlete. Challenging myths about pain is one of them, that pain doesn't always mean harm or damage. Pain can emerge at various points throughout rehab. Harnessing all the science there is about effective goal setting to set goals with your providers to enhance motivation, using basic mind-body interventions that have been used for years and decades to try to induce the relaxation response when there's pain, challenging unhelpful thoughts, some classic cognitive behavioral techniques, and exposing people to the pain that they experience with certain movements. Maybe it's the movement that they were doing when they sustained an injury. Maybe it's movements that commonly provoke pain. That exposure and that relearning is incredibly important for anyone, including athletes. Then eventually we're trying to get people returned back to sport. And as I said, psychological readiness is incredibly important. We want to have confidence in our bodies, confidence in our injured limb, that we can do what we need to do. And one of my favorite psychological interventions for this is motor imagery. So vividly imagining that we're moving a certain body part and what that looks like, what that feels like. And there's a vast literature on motor imagery from various fields. And we know that it promotes faster motor recovery and greater neuroplasticity among patients who have experienced stroke, among patients who have experienced other kind of orthopedic and musculoskeletal injuries. There's some really interesting literature showing that imagining motor movements reduces strength loss after a person is immobilized following an injury. It really is preserving that mind-muscle connection and that circuitry, which helps people regain strength faster afterwards. It helps with motor learning and sport performance. And when we do motor imagery, ideally, we're able to conjure up some of the psychological, emotional states that we would feel when we're actually performing. So you can imagine how helpful this is for an athlete who gets to experience that heart racing a little bit faster and maybe a little bit of sweating when they're imagining performing again on the field of play for the first time after an injury. If they've already been in that psychological state before the real thing, that goes a long way enhancing their psychological readiness. And of course, as a sports psychologist, I'm not only thinking about mind-body interventions for injury. This ties in with a lot of the work and research I've done in the fellowship, but there's so many applications for mind-body practices to enhance sport performance. Some of these things are used among sports psychologists, but there's a lot of room for more, a lot of room for taking what's done in the mind-body research and applying it more to sport. For example, the placebo is researched heavily, and it's not researched as heavily in sport. So how can we actually ethically harness placebo effects to increase sport performance? How can we understand the impact that anxiety has on biomechanics and kinematics? And how can we potentially retrain athletes' bodies to behave differently and move differently under stress, under high pressure scenarios? And how can we get athletes exposed to the pressure and anxiety that happens during competition outside of competition, like I was saying, so that athletes are more armed and ready to cope with that anxiety and pressure? So I'll end with those thoughts on sport performance, and thanks so much for your attention. Appreciate you being here.
Thank you so much, Jim. So I really love actually how you emphasize the humanity and everything. Like the athletes are not machines, they're human beings. It's much more complex. It makes me think of like the dichotomy that we talk about in integrative health a lot, like the integrative provider as a gardener versus a mechanic. We're not just a pile of hardware, so all right, so moving right along, we have Dr. Muñoz-Vergara, and again, please save your questions for the end. We hope to have some time for questions, Q&A to all of our speakers. Dennis, you can go ahead and share your screen. All right, so Dr. Muñoz-Vergara is a faculty researcher at the Osher Center who studies mind-body movement therapies. He graduated the T32 about 3 years ago. He has a doctorate in veterinary medicine, specializing in animal pathology in southern Chile. He has a master's in public health from the Harvard T.H. Chan School of Public Health. and he's also an avid yoga instructor. His research focuses on the effect of body stretching and mind-body therapies like yoga in acute and chronic myofascial and systemic inflammation and immune markers. And today he will be speaking on a special project that he had the opportunity to lead, which bore out of the pandemic and focuses on pre-pandemic physical activity and risk of COVID infection. Dennis?
Okay. Thank you, Gloria, for the introduction. Good morning, everyone. And also, I know there's some people from Chile watching, so buenos días. Gracias por estar aquí. Que tengan un hermoso día. Para que yo también que hablo en castellano. So, for today, I look forward to sharing the result of this observational study that looked at the effects of pre-pandemic physical activity levels on COVID-19 outcomes. After that, we're going to see infections and hospitalization as a proxy of the severity of the disease. And this was done in the Division of Preventive Medicine trial cohorts, Cosmos, Vital, and the Women Health Study, which we collectively call the COVID-19 cohort. I have nothing to disclose. Today's agenda includes a brief summary of what is known about physical activity and immunity against infectious diseases. Then I will provide a brief discussion on data set curation. And finally, we will direct to delve into our findings and what they mean to us. So we first wonder, what do we know about this association between physical activity and immunity against infectious diseases? And for that, we leverage the scientific literature, especially from sports medicine and epidemiological studies. This first paper by Nieman and Wren is an excellent review of the short and long-term effects of physical activity on the myofascial and immune systems. And right now, from this review, but also many other papers, it is known that after a single bout of exercise, depending on the intensity and duration of that bout, inflammatory processes will stimulate immunological components in a transient manner. If we add now two more physical activity parameters, which are frequency and modality, meaning type of physical activity or mind-body movement therapy, of course, things get a bit complicated in terms of biological mechanisms. But long-term studies have seen that over time, the immune system gets boosted in terms of immune surveillance against different pathogens. This is another very cool study. It is a prospective analysis done by Sao and collaborators, and they showed a similar pattern in this inverse association. They explore this among insufficiently active individuals compared to those doing muscle strengthening aerobic alone, or those doing both at the same time. And as you see here, chronic lower respiratory tract diseases, which are the blue whiskers here, this one, those practicing both at the same time had a lower hazard ratio of experience with those kind of infections. However, we wonder whether this inverse association would also be preserved under exceptional circumstances. Hence, the pandemic provided us with a very unique opportunity to explore, in a way, the resilience of this inverse association that has been described in the past. As a result, we hypothesize that higher pre-pandemic levels of physical activity are associated with reduced risk of SARS-CoV-2 infection and hospitalization for COVID-19. Now, how did we operationalize this hypothesis? That's a very important part. So as a starting point, and I will briefly summarize how we curated the data set before we formally asked this question. So these three references down here on the lower right corner provides study designs and baseline characteristics of each study population for Cosmos, Vital, and the Women Health Study. What we need to know, though, is the total number of participants that could have been part of the COVID-19 data set, which is a little bit more than 87,000 participants. However, the active COVID-19 cohort as of December 2019 is smaller. Let me show you why. Okay, so this slide indicates how many participants each RCT contributed to the COVID-19 data set. All of those participants who provided their emails and were willing to be contacted, they were sent 3 red cap surveys. And these surveys were sent in May, June, and August of 2020. They asked about COVID-19 symptoms, testing, diagnosis, treatments, severity of illness, and other risk factors. It is also important to mention that these surveys were in addition to the regular annual red cap postal surveys for those participants that were still active in trial, for example, participants that were in Cosmos. So from this assessments, we found a total of 5,890 SARS-CoV-2 infection and 626 hospitalizations. And here on the right, you can see the distribution of infection and hospitalization within each trial. So with that brief introduction in mind, we use the pre-pandemic self-reported physical activity data to explore our primary outcomes, which were infection and hospitalization. Succinctly, the physical activity question asked to the participants were converted into total reported physical activity. Sorry. Yeah, I think someone has the microphone on. Okay, so the physical activity question asked to the participant were converted into this total reported physical activity as metabolic equivalent of task, or MET for short, per week. And then we categorize this continuous variable into 3 groups. We have the inactive group, who were those doing between 0 and 3.5 METs a week. The insufficiently active group, which were participants doing between 3.5 and 7.5 METs our week. And finally, the sufficiently active, which were participants fulfilling the physical activity guidelines, and they were doing more than 7.5 METs our week. Then we employed multivariable logistic regression to estimate odd ratios and 95 confidence intervals for the association of COVID-19 diagnosis and hospitalization with each of the 2 upper physical activity categories versus the lowest one, which was the inactive group as a comparator. We also include a priori subgroup analysis by sex, BMI, ethnicity, income, and also a composite variable of CVD and cancer, and 3 sensitivity analysis that I will explain more during the results. Okay, so table 1. You all well know that it provides the participant characteristics. So briefly, 61,000, a little bit more than that, comprised the cohort of this analysis as of December 2019. On average, this cohort was 75.7 years old. 71% were female. And in terms of physical activity, 20% indicated being inactive, and 11% insufficiently active, and a staggering 69% report being sufficiently active. In terms of ethnicity, it was a very homogeneous group. 87% reported being non-Hispanic white, and in terms of BMI, 24% indicated having a BMI of equal or larger than 30. And also participants with higher educational and income levels, and those who never smoked were more likely to report sufficient physical activity levels. So these are the main finding of this analysis. So during the follow-up time, there were, as I said before, 5,890 infection cases, most of them in the sufficiently active group with 3,898 cases. And we found that sufficiently active participant has significantly lower odds of SARS-CoV-2 infection, around 10%, compared with those who were inactive in the fully adjusted model 3. Likewise, for hospitalization, we had 626 cases, again, most of them within the sufficiently active group. And we also found that those sufficiently active has significantly lower odds of hospitalization at 27% compared to those inactive in the field-adjusted model 3. For subgroup analysis, so the association between physical activity and COVID-19 differ by sex. Sufficiently active female participant had decreased odds of SARS-CoV-2 infection at 13% compared with inactive female participants. And we did not see that in male participants. Also, we found no evidence of association for BMI, ethnicity, income, and the composite variables of CVD and cancer. Subgroup analysis. As mentioned before, we also performed 3 sensitivity analyses. This is the first one. In here, we restricted results to follow up through December 2020 before the vaccination programs were widely available. And by doing this, the number of cases was reduced by 53%. So we have less cases, like 2,700. As a consequence, the significant inverse association in the sufficiently active group disappeared. However, and this is very interesting, the odds of COVID-19 hospitalization through December 2020 were significantly lower, 36% for the sufficiently active group compared to the inactive in this fully adjusted model 3. The second sensitivity analysis, because we have that information, the vaccination status, we added that to the fully adjusted model 3. Essentially, the odds ratio for infection and hospitalization did not change. However, those who were vaccinated had 45% lower odds of infection and at 63% lower odds of hospitalization, regardless of physical activity levels, which emphasizes how important it was to get vaccinated back then. This is the final sensitivity analysis. In here, we combined the inactive and the sufficiently active group in just one, so this one over here, and we use this as a competitor for the sufficiently active group. And basically, results remain relatively the same for the sufficiently active group. Now let's unravel and delve into some discussion for these results. So the main take-home message from this study is that fulfilling physical activity guidelines pre-pandemic was associated with reduced odds of infection by SARS-CoV-2, as well as hospitalization as a proxy of the disease severity, but only among those who adhered to physical activity guidelines before the pandemic. That's very important. And also our findings parallel result from other COVID-19 cohorts in here in the US. Lastly, and if this association is true, what are some potential biological mechanisms involved? So I will mention 4, which are the classic ones. So first, physical activity enhances immune surveillance of by increasing the activity of different immune cells, such as natural killers, neutrophils, and macrophages. 2, physical activity modulates the inflammatory process through the secretion of different mediators, including cytokines, myokines, and a huge variety of lipid mediators, including oxalipins and endocannabinoids. 3, biologically, biomechanically, physical activity increases blood flow, hence the shear stress over the free surface endothelial cell, which trigger the production of nitric oxide, which counteract the, for example, the oxidative and pro-inflammatory effect, in this case, of a systemic infection. And 4, and this is more like a top-down biological mechanisms, physical activity also improves neurocognitive processes and optimizes the stress response, for example, using the HPA axis and the autonomic nervous system. And with that, I leave the paper in case you want to look for. Here's the DOI, and you can download it and read it Thank you.
Thank you, Dennis. Another great example and illustration of sort of whole person health and how all of the different systems interact, musculoskeletal and cardiovascular and immune function. All right. So as promised, we'll open this up for questions. We can get all of our speakers back on the screen. Wonderful. Great. So if you'd like to ask a question, you can go ahead and raise your hand. Otherwise, there was one that came in earlier through the chat or the Q&A. I think it was just a clarification question for you, Wren. The question was the chiropractic intervention just neck or total spine therapy?
For both of the studies that we use chiropractic intervention, it's limited to the cervical spine.
Okay. So I guess let me see here. I hope I can actually seeing everybody. So I don't see everybody, but I think if you raise your hand, you will show up in my left corner. So Dan, let me know if I'm missing anybody, but I'm going to go ahead and follow up actually, Wren, with a question for you, just taking my moderator's prerogative. I just thinking about, the mind-body connection. So I was wondering, so what are the implications of adding in that last study that you talked about, adding the movement therapy, like adding the Tai Chi to the chiropractic intervention for neck pain? So how does that impact sort of the cognitive, emotional components? As well as the physical impacts on neck pain?
Yeah, that's a great question. And I will say I'm probably not the expert on this. I know we have Peter in the audience, but from what I understand, synergy really is the most important part between the two interventions. So making sure we emphasize kind of the top down and the bottom up components of chronic pain, just to really address any of those facets and offer more comprehensive treatment. We know that people like with kinesiophobia may be hesitant to fully participate in some of these interventions. So if we can kind of address that top down and then the bottom up with the chiropractic, it can offer more benefit.
Yeah, wonderful. Any other questions? Otherwise, I'm going to keep going with my questions.
Gloria, I see one from Bobby.
Yeah.
You see him on your screen, but Bobby
I don't see him. Okay.
Hey.
Please go ahead and unmute and go ahead and ask your question.
Hey, how's it going? It doesn't have like a raise your hand kind of little icon thing at the bottom, so I had to just put my hand up. Sorry. So I guess I have a question for Wren. So basically kind of what I'm understanding is that like imperfect gait is pretty much normal, but alterations in gait is primarily secondary, whether it's due to injury or fear avoidance, various psychosocial issues. Is it fair to basically say that you can't really like kind of perfect gait per se? Like you can't say like, oh well, you're not going, you're not pressing your big toe down hard enough, or your knee is going a little bit more valgus whenever you're walking. Try to correct that. It's more of just kind of understanding the reason for why the gait is altered, and then focusing on that, and then letting things work out naturally. Is that kind of what I'm understanding whenever you were kind of talking about gait analysis?
To a certain degree, yeah. I would say that we don't know, I would say causally, what really is making this gait alteration occur. And that's kind of the intention of the theoretical model, is to show what all these things are that could potentially contribute to any gait alterations. And I will say one thing that's not well reflected in that theoretical model is that that relationship is likely bidirectional. So we don't know if it's the gait that could be contributing to chronic pain, or if it's chronic pain that's contributing to gait, and kind of along that whole pathway, what pieces are contributing most is really what we're trying to figure out. So I wouldn't say that it's going to quote unquote work itself out naturally, but I would say that there's a lot of components that would need to be addressed in order to really regain some level of, and it wouldn't even be optimal movement, but just kind of safe movement in a way that wouldn't exacerbate further mobility reductions.
And to just follow up, just piggyback on the previous question, the reason why you guys, or let me back up and kind of gather what I'm asking. Is it possible that part of the reason for why there was such a significant change whenever you did cervical spinal manipulation to patients with altered gait and fall risk might be because of like a mild situation of cervicogenic vertigo in a lot of these cases?
Could you repeat the question? I guess I'm not understanding it fully.
So my understanding is that the study that you showed previously was about cervical spinal manipulation in its relationship to improving gait and reducing fall risk. Did I misread that?
The retrospective analysis?
Yeah.
Yeah, so that was just spinal manipulation, and then the outcome was an ICD-10 code of falls. So not necessarily gait, but gait is just a proxy of something that we look at kind of in a more clinical setting that could be a predictor for falls in the future. So not a direct measure of gait, and that's one of the limitations of that study, is that it kind of oversimplifies both the intervention and the outcome.
So what could explain why cervical manipulation affected fall risk?
If I had the answer to that question, I'd probably be a millionaire. But I will say again, causally, it's really hard to know, especially with big data analyses like that. That pathway is very unclear. It's a huge limitation of studies like that. But the pro is that we have these big numbers and we can detect these changes. And then the next step is kind of answering that question that you're asking as well. So that's kind of the goal of all of this, is getting to that question and answering it. So it's on the right track, but I don't have a good answer for you right now.
Do you think
Yeah,
that it might
obviously
have
there's
something
lots
to do?
more study, research to be done to sort of get there. So I'm sorry, Bobby, to cut you
No
off.
worries.
I think
Yep.
it'd be great to continue, the discussion offline. I think there's a lot
Sure.
of interest there. So, but I know we're out of time, but I would love to actually just, we're out of time, but well, I see that Jim, you've been answering some stuff over the chat. So thank you so much for that. I don't know if you want to address just very briefly the last one from Karen Kilgore talks about youth. So movement seems integral to physical, emotional, and mental health. I'm concerned that over time we are ignoring synergistic effects of movement and cognition and emotional health and education systems. So any thoughts on expanding to younger folks? You just want
Yeah,
to
I
address
think
that maybe very, yeah.
sure. Yeah, I can quickly try to address that. It's a really big question, and it's a really good question that this is overlooked. You can think about school systems, you can think about physical activity time that is now starting to be re-emphasized, which was once emphasized, and mandating, more time for movement and activity, which I think is incredibly important. And in terms of emotional health, right? We are training athletes, in my case, in kind of mental and emotional skills to cope and perform better. That's not part of the standard curriculum for students, for young people. And I think that's a huge oversight. If we're going to allow some of the best performers in the world to benefit from this, who arguably might not even need it as much as younger kids, I think that there's an inequity there. So I would love to see some of the mental and emotional skills that we teach as sports psychologists, other practitioners here, integrated earlier on. Earlier intervention, I think, is crucial.
Great. So again, we're out of time, but I just see this great question here, and I'm just going to read it, but and not have you guys answer it. Everyone can think about it. And it was, does your research help to explain how Noah Lyles, ran the 200 meter? Of course, it's one of the track and field folks that ran while he had COVID. So maybe a question for both you, Jim, and you, Dennis, but something to think about. All right. Thank you all so much for 3 wonderful talks, and really, again, just thinking about how all these systems come together, the movement, um, the musculoskeletal system, the mind, cognitive, emotional, immune function. Really a nice illustration of mind-body connection and whole person health. So I'm going to actually share my screen very, very briefly, just for some announcements for future talks here. Go. Oh, here we go. Yeah, so please join us, everyone, September 10th for a very special Grand Rounds. This is Dr. Don Levy, who was our founding medical director at the Osher Clinical Center, who's retiring and is going to be really giving a talk on, reflecting back his 25 years of practice and looking forward to what integrative health, will bring in the future and what it means to him. And it's at a special time on the 10th at 1 o'clock to 2 o'clock, and it's going to be followed by reception at 2 o'clock to 4 o'clock, and that everyone is invited to come to. So please mark your calendars for that. We also have a very special October Grand Rounds. Tuesday, October 1st is our Kogan annual lecture. It's going to be given by Dr. Wayne Jonas, who's president of the Healing Works Foundation, and he's going to talk about cancer in the context of integrative medicine and whole person health. And again, that's also at a special time, 1 o'clock to 2 o'clock. And then on November 8th, we have a virtual, the Osher Collaborative is hosting a virtual symposium, Healthy People, Healthy Planet. And you can find all information about all of these on our website, oshercenter.org. And then last but not least, our Osher Network Forum, which will be December 9th and 10th. This is going to be a hybrid event. The in-person piece at Bourne's, at the Martin Center. It's going to be a focus on high-tech medicine, soft touch healing, advancing innovation in integrative health, and really some amazing speakers, within academia and industry, bioethics, talking about all the issues around sort of cutting edge technology and what this means for integrative health. And our call for abstracts is open. The abstracts, please submit so you can be a participant at this forum. I think the due date is September 30th. All right, and with that, I close, and thank you all so much for joining us for today's Grand Rounds, and we'll see you next time.
Thanks, everyone. Keep up the movement for those who are moving. Very good.
That's right. Go hard.